Professor Berenstein, it is quite a pleasure, an honor to have you here as part of the Link family in this version, Paris 2025. You have delivered an amazing lecture. We were all inspired by the messages and everything that comes as part of our future, especially for the younger generation, all the people that you have trained and inspired like myself. If you can summarize like the take-home messages after delivering this amazing lecture.
Thank you very much, Danielito. What is the message? The message is that access is the key for us to do what we're doing and to take this to the next frontiers. And we're introducing the term of articulating technology. Articulating technology means instead of having catheters that are pre-shaped that just go back and forth, we actually now have the ability to have, imagine the nose of an elephant, the ability to articulate so that we can find the different places where to go. We can actually navigate without the need of a guide wire.
Right.
We can actually navigate injecting contrast material to see where we're going. It's a complete revolution. What we call interventional or endovascular will really become true endovascular surgery. Why? When you have the ability to articulate and be able to move something within a vascular space, we can actually gonna develop stitches. Then we're gonna have one catheter with a needle. You can have another catheter with a loop, so that you can actually start on really going not only through the wall of the vessel, but to the different layers of the vessel. We're going to have maybe 1, 2, 3, 4 different articulating technologies. Robotics coming. This was designed for robotics. So I think that the access that we're getting now will completely revolutionize the field. You saw all the endovascular trying to put a web in a certain position, and you put them in and out and see, hopefully we'll get there.
That was a very difficult case.
Okay. Yeah, but if you had the articulated technology, you would have put it exactly where it is. More than that, if you look, and this is the mesh. I can look the mesh, I can see you, you can see me. If I turn it just a little bit, the light no longer goes there. So we're going to be able to turn, and we have already patients in which we change by 1 degree, 2 degrees, the orientation of the mesh, and immediately you thrombose the aneurysm.
So an steerable, shapeable catheter on its own, with minimal effort, will change the skill set of the younger neurointerventionist. Do you think the skills that we learned from you, from Professor Chappell, from many people to steam shape the catheters is going to be a thing of the past?
Yes, but I have people afraid of innovation. I've had many times that question. If the skills, people won't have skills. People won't need the skills because it's much easier to do. I mean, do we have a car now? Does everybody walk from here to Medellin? You take, are you going to drive there? No, you're going to fly. So, we have to advance. The technology will take us. Our knowledge will be a little different.
I remember seeing cases from AVMs transvenous where accessing the part of the draining vein from, especially if it's a superficial cortical vein, very difficult, very risky. So this is the tool that will facilitate.
Yes, as you saw in the presentation, you can go and try the superior sagittal sinus and angulate.
Correct.
On his, this.
That's what we were thinking.
Yeah, this is how Rene now believes in this, because it took him like 1 minute to get into the cortical vein. He didn't have to do what I call endovascular malabarisms. To try to do gymnastics. It's so easy. That you can actually do, but that's going to take us to do more things, more diseases. Today what are we treating? Hypervascular disease, AVM. We're treating atherosclerosis, vascular disease. We're treating aneurysms, vascular disease. But, we're going to go with this technology. You're going to advance, for example, hydrocephalus. You see that people are now going, what Malek showed us,
yes,
to go through the petrosal sinus, but they have no orientation. They just pierce, sometimes pierce this way, sometimes. We're now going to have an accurate way ability to do that.
So that device most likely will be delivered or through that catheter, through this new technology, or aided by that.
The catheter is the access to.
Okay.
And then we're going to be designing. If you tell a designer, an engineer, you have this tube and do me coils to put. So the engineer is limited by this tube that doesn't do anything. So this engineer develops 3D coils and things like that. But if you tell the designer, you have the ability to go to 1 o'clock, to 11 o'clock, to 6 o'clock, then he or she will develop a device that uses that technology. So it's just limited by one thing, imagination.
I have mentioned to you, and I showed you a video. You're one of the pioneers in this field, and to me, to many of us, you've been absolutely inspiring. And so one of the frontiers that I really want and hope to get eventually is the possibility of treating tumors and be part of the development of what we could call neurointerventional oncology.
Oh, it's a great future. It's a fantastic future. Look what's happening in the liver and the prostate. The liver, cancer of the liver is completely revolutionized by radioembolization. Okay? What do? They use iridium particles. When you embolize a territory with particles, they will just stop by their size. But then if you have 2 or 3, they will just block here, and then you have clot. So we're now developing a liquid embolic agent that is radioactive, that you use it like the glue. So now we're going to go and do endovascular radiosurgery. So you're going to go, how many AVMs it can go? Almost 20. How many can we close? Not so many. And now to try to close, as you saw here in the course, you got to take certain risks. You got to keep on going. What if we can go to an AVM and put enough glue that gives you beta radiation or alpha radiation to be able to thrombose it? What if glioblastomas would spread through the white matter? We can actually get intravascular radioembolization.
So similar principle for treatment of endovascular treatment of tumors.
Correct. That would be, I think, is a tremendous potential. People are going to try, chemotherapeutic agents, changing the BBB, blood-brain barrier, so that you can get, water-soluble agents to out. But if you can actually do some of the radiation without damaging the skin, the muscle, the bone, the brain itself, because you go right into a targeted radioactive. And there are things now, there are certain companies that are looking for receptors, N1, N2 receptors of gliomas. We now can find radioactive targeted things that we can inject, and it will go right to the tumor. So the future of neuro-oncology is phenomenal.
We've seen some pilot preliminary studies of endovascular biopsies and RNA, some genomics of everything obtained endovascularly, which I believe is also part of the future, no doubt.
Yeah, no doubt. So again, imagination it's such a great picture. The catheters that we have now, the access, the imaging technology that we have, it's incredible. And then endovascular optics are also coming of age. So you actually, like they were saying, is that device, the web, is it sticking out or not? You put the OTC and you look into exactly where it is. So now you can have, with this articulating catheter, reposition it exactly, and again, see it from the inside.
So intravascular ultrasound, intravascular optic
film. Yeah.
Right. Well, Professor Berenstein, pleasure again. Thank you so much for your time.
You're welcome.
For sharing this wisdom with us.
Thank you.
And I hope you guys follow these developments in the next upcoming years. Led it by him.
I just need another 30 years.
and the younger generation as well. Thank you.
Thank you.